right now have some medical terminology that y'all can look at while y'all are chat. What did she say? Starting just a little late because of all that changes and stuff, but you're testing Tuesday. Best of luck. Oh my gosh. Super nervous. Try not to be too nervous. Just put it out there in the universe. You are already are passing on Tuesday. You're not just taking your exam on Tuesday. You are absolutely, that's the day you're passing. Yeah, absolutely. Has anybody taken it in person? Or when I took mine, start back up at the top with these definitions. When I took mine, I took it in person, but I thought that exam was pretty wordy. I was like looking at the words, but I was just there just to copy down the codes and the definitions of some vocabulary terms that they were going to be using on the exam. So I thought it was wordy, but it was in the printed booklet format. When I took it online, after I studied the codes that they had put on the printed one from each chapter, I figured out why they were picking those codes, because they were pretty similar, or they had the same beginning annotations in the beginning of the descriptor. So I figured out that those are the codes they like to pick on. So I put up late last night working on these. This one's already got the answer for you, but it's some of the newish kind of questions that they're talking about in some of the E&M. And sometimes they might not even ask you a number code that might help. So this one is E&M codes enable a physician to be en route reimbursed for all of the services except for which one. And it is their continuing education classes. I believe on YouTube, maybe. Let me check. Do not read the questions. Absolutely not. I have well over 75 questions. We are going to do the questions in the time that it takes for the exam. All right. First question. So when I look at this, I'm going to make sure I pay attention to just what they're asking me. I don't want to know anything other than the question. So we need to know the services are provided at different levels. We know that. No big deal. Guideline states we should code to the level of what? At least the number, all key components, or the number of diagnosis codes. We know it's not diagnosis codes, right? Anybody want to take a guess? Is it A, B, C, or D? All components must meet or exceed. Yep, we have that too. 3 components must be achieved, at least one of 3 components. This one is all key components need to be met or exceeded. So it is C. Good job. It can, and time is one of the components. So they're trying to trick you right here. There's 3 components. Good. Thank you. Awesome. So this doesn't say just 3 components. This is 4 components actually, because if it needs the history of the exam and the MDM, time is your 4th component. So they didn't say a number. So that's why it was tricky. All right. So for this one, another wordy one. If I'm thinking about our history review of systems, our family history, and personal patient history, just those 3, we're being asked which term describes patient's symptoms and problems from the time onset since the last time they were seen by the physician. Where would that go in the chart? Would it be HPI, ROS, PFSH, or H? Yep, A. Y'all all got that right. Yep. Be sure you know your definitions. If you don't know your acronyms to PFSH or H, be sure and screenshot this and write those in your E&M thing. Super important. Another one. Which one of these components determines the intensity of the cognitive labor of the physician? Must include when determining the proper code. So we're talking about the physician's cognitive labor. EM. Yep. Cognitive function of the physician. Funny. Yep. Which of the following is not a type of E&M service? Which one of these is not an E&M service?
Surgery?
Surgery is not an E&M service.
Right.
A home care is an E&M service. Yep. It's just surgery because those get surgery codes. Kind of a tricky one. If a patient sees two different doctors within the same specialty office, what factor will determine if the patient is considered new or established?
No, existing.
They'll
Yeah.
ask this in several different forms on the CPC exam. Is it the office hours, the patient's last visit to the doctor, subspecialty, or when the patient was treated the longest? So silly. Subspecialty. Always look for that word. It's always going to be part of your answer for that one. Is subspecialty or the word 3 years. Anytime they say
Right.
that. Admit all.
But I didn't like the way that question was worded.
Some more. Sorry, what'd you say?
Oh, I thought I had my mute button on. I thought I did, but I didn't like the way that question was worded. It was.
I
it was
know,
confusing.
right?
Yeah.
Sometimes they get really crazy with those, the way
like,
they
what the
word
world?
them.
Yeah.
When you're seeing two different
Different?
doctors within the same specialty office, that's why I love I know some of the questions seem very repetitive, but they're all worded differently. And
But
that
it's like,
wording
if
can
it's in
really
the same
throw you off during
specialty,
the middle of your exam, for sure.
but what I don't understand is if it's in the same specialty office, then how could C be the answer?
Because they're all specialty offices.
Okay.
Yeah,
That
yeah.
is a tricky question.
it's
I don't like
awful.
it.
Yep. They're all specialists. Yep. If a patient saw a cardiologist at the specialties office, but then sees another cardiologist in the same specialty office, we know they're established. If they see a cardiologist at Kaiser Permanente, but then they go see a neurologist, we'll know they're a new patient with the neurologist. So it just depends on their subspecialty. It's the slightest thing in some of these questions that can really throw you off. But yeah. All right. A disease condition or symptom that is the reason for the patient's encounter is known as, not hard, self-diagnosis, patient history, presenting problem, or physician diagnosis. Yeah. I like presenting problem too. Yep. Why are you sliding over that way? Stop it. Come on. What are you fussing about? C is it. I think I'm touching the screen down below too. All right. The term used to describe the patient's symptoms, problems at the time of onset since the last seen by a physician is known as. So this one's almost the same thing, but worded a little bit different. Terms used to describe the patient's symptoms or problems from the time of onset or since last seen by a physician is known as. And remember, if you don't know those definitions, get them written in for the acronyms. A, history of present illness. When characterizing a patient's HPI, does an extended HPI typically include how many elements? So this is from my notes on like page 11, or if you don't have those, you can write those in. That second column on that page, if you're in the 2022 book, has these areas. And so if we're talking HPI, how many does it have? Okay, good. So for this one, patient's HPI typically includes how many elements? B, 4 or more. How many individual body systems are recognized in the review of systems? And that's up here in the top part of this page, our lovely page. How many are recognized total in the body? I may not have it written in right here because we've got 8 plus, but how many are there in total that are really listed? And it might be down over here on the side. How many body systems? This is something I should write in here, and I don't have it in my notes. So, you know, when we figure out the answer, we're going to go to our notes and we're going to write total ROS equals B. You're right, Van. Good job. 14. And there's the complete list. If you wanted to get even more fancier, and you could actually write them all down. The constitutional is one whole thing. So that equals one complete review of systems. Eyes is by itself, all that kind of stuff. How do we see? Okay. E&M coding, what is the highest and most descriptive level of history? Right now, I'm on page 11 in my 2022 CPT book. The severity of chief complaints is part of the E&M service component of what? Severity of chief complaint in E&M is part of what? Is it symptoms, coordination of care, review of systems, or nature of presenting problem? It is D, guys, nature of presenting problem. So chief complaint is not C, review of systems. Chief complaint is nature of presenting problems, okay? E&M coding, history, physical exam, and medical decision making determines documentation requirements unless the physician applies an E&M code based on what? Just so you know.
Study physical examiner, medical decision maker. Sorry.
A is this one, the length of the visit. Don't get confused with appointment time or anything else they might put in here to make you confused. It's only the length of time because we either are going by MDM, history, and exam, all three. We can't forget about them, or we're doing time. All right, E&M coding, an initial observation care within a hospital facility typically lasts how long? We're looking for coding associations. We do have 2 that are in the 24s. Probably our answer to that or guidelines, probably right here. Probably some in here where we would have it. I don't have this listed in my notes. I should. Probably. I'm just admitting some people. Yep.
B.
So let's see. We got C. It's not B, it is C. Oop, I can't draw. I forgot. Unless I do my finger like that. But yeah. It is C. 24 to 48 hours. The other one was 24 to 72. That's 3 days. Or more. I think there's a cutoff for that. Although I do have a practice question coming up with a person who's been in observation for 3 days coming up, but their question did say typical. So our patient example coming up later will be a non-typical, I'm sure. Remember, there's nothing always in coding. A lot of people ask me, is it always going to be this code? Is it always going to be this way? No, not always. Typically, yes. All right. When determining a patient's HPI, be sure you know those acronyms. How many elements are recognized in order to characterize the patient's complaint? So we are under HPI. Presenting problem. Around with the HPI. We got 8, 5, 4, or 6. I got one answer. A, C, maybe. 6. It is 8. It is our biggest number. It is 8. HPI equals 8. So even if we wanted to go down here, that pen ain't gonna write. Get those things added into your notes. That's why these questions are so helpful. And if you don't have any notes, this is a great way to just go through 85 questions and get all those notes written into the book during this live or after during the replay. Which of the following E&M codes would require extensive documentation to support the code? Require is important. Yeah, nope, nobody's getting the answer right. Nope, nope. It is not a progress or note. They can be super vague. There you go, guys. New patients. Your new patients to qualify for a new visit. Yep, we got to be more extensive on that. Perfect. Yay. Don't feel bad. You're meant, I've picked questions that I hope you will get wrong. And if you are participating, that is a wonderful way to make sure that you learn something from this. You don't want to get everything correct. You really do want to miss them. And don't be afraid to just shoot a number out there and take your best guess. You learn better and faster and remember more if you've got it wrong the first time. So that's great. And I try to pick questions to make sure that you guys get stuff wrong. Which level of MDM is considered the lowest? This one's easiest. Is it straightforward or low? It is straightforward. Yep. That one was an easy one. The act of arranging administration to a rehab facility or arranging home care is all part of what E&M service component? Is it part of the case management or coordination of care? All of them start with C. It is D. Good job. It is coordination of care. Just don't let them confuse you about case management. Good job. When characterizing a patient's HPI, a brief HPI typically includes how many? So I got the answers here in my notes. How much is brief? 2 to 3, 1 to 3. It is 1 to 3, 1 to 3. I've got it written a couple of times right there. Terms used to describe a patient's symptoms, problems from the time of onset, since the last time they were seen. Have we done this one already? This seems like a repeat to me. Symptoms. These questions are from every service that I bought. Some of them might be from AMA's books that I have. Oops, sorry. AMA's books that I have. They might be from AHIMA. They might be from APC, but they are from those 3 legitimate places. If they're not from AMA, then it's from AHIMA or it's from APC. So this one is history of present illness. Yes. The terms used to describe a patient's symptoms. We already did this one. How many times did I repeat this one? Which E&M component is used to determine the intensity of the cognitive? We already did that one. Doctor. I need an editor. Okay. Diagnoses. This one's good. When discussion of diagnoses, test results, and treatment options or follow-up is all part of what part of the E&M component? We're talking about the diagnosis, the test results, treatment options, and follow-up care.
Follow-up care?
D, counseling. Isn't that crazy? I would have thought coordination myself. I would have gotten it wrong. But it's talking about the E&M service. And see, that comes from the physician. Who does coordination of care? The RN or LVN or whoever they've contracted with from the health plan to do the discussion is RNs and the patient who are doing the coordination of care for risk assessment and stuff. They have discussions with the patient too, but I think it's more so that you've got to keep thinking E&M as doctor, E&M as doctor. Yeah, but I certainly would have probably picked coordination of care. because I would have just been wrapping that up as a nurse instead of thinking of it from the doctor's point of view. Your own work history in these areas of healthcare will influence your answers. And you got to remember that we're only thinking from a coder's point of view, which is the E&M service, which is the doctors working on the patient. But yeah, I would have so gotten that one wrong. Absolutely. All right. Finally, some numbers that y'all want to play around with. First thing I want to know is, I know off the top of my head that this one is observation, isn't it? And this one's admit to hospital. I can't write as tiny as I should. And then 3.8, is that discharge? I think that's discharge. So with those kind of things in my head, what is bestest way to keep up and listen and follow? So this one is an observation code. I want to make y'all some flashcards so that you will know what these numbers are as I do. Admit, hospital, and I think this one's discharge. So we have a patient who is admitted to the hospital and discharged 4 hours later. What kind of visit are we doing? But even when you're doing questions like this, please go to the answers first. Figure out what your headers are on all these codes, because we know they're all going to be different. And just knowing those headers gets me to look at this question from their point of view. One thing you need to remember for everybody that picked the answer A, which is incorrect, is that Medicare does not pay for any observation status for any of their patients. They get to fall out of line of everybody else, and that patient would have to be coded as inpatient. So the cool thing about 2023 is they're getting rid of observation, and they're going to make everybody be coded the way Medicare is. So these codes will be deleted next year. But for this particular question, for today's date of service, or if you're taking your exam like somebody is on the 30th of December, the answer when you see Medicare is always admit hospital for Medicare patients. If it does not state an insurance, then it will be your 34. Okay, I hope that makes sense. All right, so for this one, I know that we're doing admit hospital. I know this one is critical care. Same thing here. I've got admit hospital, critical care, and then this one's got critical care and then admit hospital with it. This one has the 25 modifier. This one doesn't. So if I was going to add 2 E&M services, I have to have my 25 modifier. So no matter what, this one's a coding irregularity. So that one's going away.
Yeah.
I just need to know, did I do 2 E&M services on a patient today, or did I just do 1? That's what that question is telling me. No. So critical care typically is just 1 or 2. The number is there. But in hospitalization, when you admit a patient, you can do them as a 221, a 222, or a 223, depending on the high level of MDM or time that you need to do. This one should typically just say 1. I don't know who wrote the question. I just copied and pasted it here. But typically, this would just be a 1. There's really no reason to put the X. They could have just put the 1 because it's the only code you could use. But they're just being the way they are in writing their questions. So let's check out our question. We have a Medicare patient, so we know we're not doing any observation, but none of these answers are there, so that's cool. They were treated for a fall, and I see the word returns to the hospital later with a heart attack. So we did 2 visits. I would pick 2 and move on with my day. We can bill 2 visits in the same day. Absolutely, because they both got 2 E&M visits. You would evaluate that patient totally different for that fall and hurting their hip or whatever. And then when they come in with chest pain, having a heart attack, that would be a totally different evaluation and management. So most definitely. All right, CPT code 99281. We run to that code. 81.
Yeah.
We're under ER. We know right away we're going to be A. That's all there is to it. Plus, I like to memorize that any one of the ones in 8 are in ER. They're going to change this code next year. It is not going to be E&M. What is that? Straightforward. It is going to be a nurse visit in the ER, which is cool, like one of our E&M visits. So that's next year, though. But like you can come in and just get your stitches removed in the ER, like we saw you in the ER 10 days ago. You don't have a primary care physician, whatever. You come back to the ER and you see just a nurse just to get the stitches taken out. They have that now. Doctors and hospitals had a really hard time coding that scenario, which happens all the time. I am doing the questions, and these are all from 2022 point of view. But I will have about 30 minutes at the end that will discuss some 2023 scenarios for sure. But since I'm here, I'm just saying that will be a nurse visit next year. But right now, it is still an ER visit. And it'll still be an ER visit next year too. It's just an ER nurse visit, which is exciting to have because we need it. All right, which of the following E&M codes would require extensive documentation to support? We've already done this one. That one's our new patient. Good gracious. All right, code 99324. What is that? 99324. Don't forget that when you're looking up codes, stay up here in the top corners because those are super important. It will help you get through the pages. It's a new patient for what header? You gotta go over here. Right there, domicile, and we'll just pick domicile. Just look for your header. These codes are deleting next year. All right. When characterizing, oh, we've already done that one too. B. Good gracious. If a provider states in their documentation that a medication was reviewed and reconciled, and they are managing the patient's medication, what is their risk level? Are we low, moderate, or high? And this is where that page 17 comes in. Super handy. We've got our differences with minimal, limited, moderate, or are high. And this is the column that they're working out of. Yep, we are moderate. Our prescription drug management is listed here, and that's near our moderate. Yep, all right. They're all new patients, level 2, level 3, level 4, level 5. What we need and what I would be thinking of is I need an exam, a history, MDM, or I need time. So I'm just going to look through my questions, see if I have a time. If I don't, nope. And I don't have any MDM, I don't have any history, and I don't have any exam. So I just got to look and see what diagnoses are going to lead me to this. If a patient has a UTI, what kind of history would I have? Would it be low, minimal, straightforward? We would just ask them if they've had it before. They could have a chronic history of it, which could be chronically high, or they could be, this is my first ever. Never know. We don't have that documentation here. It doesn't say anything about it. Our exam, you can tell that the patient didn't get anything done. They didn't look in the eyes, ears, or anything else. They just got dealt with that. So it's going to be super low too. And then there would have been an RX probably needed for that, right? We might have done a UA. So we know that the O2 is usually for patients that just get OTCs. You go home, stop eating, go to brat diet, you'll feel better. This I typically keep at my 7-day RXs. This I typically keep at my 30-day prescriptions that change your life. You're going to be on this drug forever. And then this is usually test at the hospital. You're fading fast. We got to intervene, and you're probably going to get sent over to the hospital. So knowing that this is a UTI, patient doesn't have any other comorbidities, then we would just do the 3. And that's what I would pick. Yep. And I put UTI somewhere around in here. But yeah, UTI, there it is. An example is UTI. Are we going to be minimal, low, moderate, or high for a patient who has a UTI? And does this one have the diabetes? Now we've got 2. We've got 1 chronic condition and 1 acute one. When we're
See.
using these little charts, you can say that we've got 1 acute condition, but down here we could have 1 chronic condition with 1 acute condition. So we put our diabetes and our UTI patient down here, which ends up being our moderate. That's how I keep up with that. It poses a bigger threat because they have kidney. Remember, they've got a correlation between kidney disease and diabetes. So when they come in for UTIs, it's a much bigger risk with that one for sure. More so than hypertension with it. All right, we know where we're going to run. We're going to go straight to our 99291. And we're going to look for our critical care chart. All we need to know from the question is time. And that's it. I don't need to know who they are, what's going on. I just need to find time. This one, we've got time listed in multiple areas. So we do have to do some more investigation. I have to make sure that all 3 times are considered critical care before I add them all together. We've got ventilation management. So 62 is good for critical care. 55, what did they do? Documents an additional, the same doctor for critical care. Okay. 55. And then this one, 29 minutes was for same day endocrinology coming by to check on diabetes. No, we won't add that. So we've got 7 and 11, 117 minutes. I'm going to check our book right here. 117 minutes. Yep. We're going to do our 992 times 2. So the ones times 3 we'll get rid of. And then are we going to code this code with it or just that one? Are we going to do our 9923? Right? Everybody saying A. What else are y'all saying? A. Oh, your computer kicked you off. No worries, Sarah. It's okay. Y'all are correct. We've got, yep, our typical 25 minutes was not to be included in on that one at all for any reason. Another one that's just a level 2, level 3, level 4, level 5, super easy. We're thinking about OTCs, 7-day RXs, 30-day RXs are going to the hospital. We've got 1 chronic condition, not at goal, limited data, no prescription management. If we go to our, right here, we've got limited. Limited is going to be in our 3. They've got these little notations right there that help you pick out which one you are. So, yep, we're going to be the 3. Super helpful when it does it like that. They're going to get harder as time goes on. If we go to our 99, we have some cases coming up too. They're going to take us on a lovely trip around the block. We're going to be doing our aim physicals. I love these codes, right? These are, I don't know why, just turning to them are super difficult sometimes. And then we got our 12 and 13. But we're still all over the place. These are going to be for our counseling. Where does BMI management go into? Are we going to be in our 1s or are we going to be in the 11 or 12s? Which one does? And our keyword is risk factors. And you see how this one has our risk factors notated in there? Definitely doing our risk factors. And we only did 10 minutes. So we'll just check with our time. Yeah. We still get to do the 01 for that one, even though it didn't make the 15-minute route. It made most of it. It's just preventative. It doesn't mean that they are, but it's likely to counsel the patient. All right. Got E&M. We got a level 3. We've got an established level 3. We've got a new patient, level 2. We've got E&M based off documentation of MDM, or we got a 908, which is a medicine in the back, but it is on every single one of the codes. Some sort of 908. It doesn't matter as long as we get the first code correctly. So let's check out and see what's going on. We've got if a physician documents an established office visit that's 20 minutes, and then they did an additional 35 minutes for psychotherapy, what would be coded? 908. 32. 32. How many minutes? We got 30 minutes with this one. This one's 45. Add on. So we would do just the 33. Yeah. So 33 is a 32. What's 32? That's 30 minutes. Yeah. Make sure our header is correct. Yes. 30 minutes. Right. 32. I like 32. Plus it's in 2 of your answers. So you want to hyper focus on those. It's in A and C. You can eliminate just B right away and D because it's not the same when you use the similarities. Then you have to figure out what would be our E&M. And there's got to be a reason why ABC would write it out like this and why they're asking us. And it's probably because they gave us something to trick us. So if you're at the 213, of course it says right there 20, 29 minutes. But there's a guideline tied to this question, and you can't, if you're doing psychotherapy, you have to record psychotherapy with minutes. There's no other way to do it. You don't do it by E&M by history, exam, or MDM because the psychotherapy is only dealing with psychotherapy issues. They're not doing eyes, ears, all that kind of stuff. So for psychotherapy, because we have to do psychotherapy for time, we have to do it based off time. So because we can't do psychotherapy with a history, an exam, and a MDM, we have to use time on it. Then you can't use time to use for your other E&M visit. So on the 213, we can't use 20 minutes. We would have to query the doctor for his MDM or her MDM to be able to bill this one. So we could not actually bill it if that's all the doctor gave us. So yes, psychotherapy is your key word. If you ever see it with time and then they want you to bill another E&M with it, just like the scenario, know that you can't bill both of them with time. It's one, this one's the only one that can be billed with time. This one would have to be based off the MDM. There's your answer for that one. All right. When reviewing telehealth claims for office E&M services based on time, which of the following is not required in a provider's documentation? Some of you guys have seen this one before. Is it service type, platform being used, consent, or total time? Actually, it is consent, guys, because you're not required because the patient logs on from home. That implies consent since they engage their own personal computer to come to you for telehealth. And yeah, it's just patient consent. This is the list that I've never shown off before of items that must be included during a telehealth medicine. You must have your audio visual service, the patient's location, platform being used. It all has to be in the patient's chart. Yeah, it's not required. It is basic practice, but it's not required. And neither is the patient's location. Is actually not required either. But total time, of course, all that kind of stuff. When an emergency room provider is stabilizing a dislocation fracture, screen is blurry. How's that? When an emergency room provider is stabilizing a dislocation fracture, what should we code? The application of the cast, the fracture treatment per the location of the fracture, modifier 54 or 55? What do you guys think? We're in the ER and a provider working on a dislocation or fracture. Yep, you are correct. Yep, I have cases too. Yep, they're coming up. This one is absolutely because of the word stabilization. And that's all they're going to do is just stabilize the patient until they can get in with ortho, and then they'll document all that other stuff. So yeah, it's just A. Absolutely. Achieve this. There we go. If you don't know those acronyms, be sure you know the acronyms. I do have the definitions coming up real quick. FQHC. Which one of these would be most appropriate when dealing with mental health visits via telecommunication? There she is. Still blurry. We've got two with the same answer. Start off with the same. That would have me looking around at that one for sure to see what's going on with our G. We've got our HIPPICS book to look at for that. Yeah. We've got D. Don't forget that the federally qualified healthcare centers is what the FQHC is. We've got plenty of room up in these front areas. Y'all could write some of these acronyms on anywhere y'all wanted to. Plenty of pages. I have our definition of subjective objective assessment and pain plan up there on page 5. Plenty of room. We can write a list of these E&M acronyms to help out. Psychotherapy, again, another one of these questions. We've got one that's exceeding 80 minutes. What would we bill? What is our guideline for that? So we were back there at those 908, 90832s area. So you're going to have your guidelines right before you code this section. Right here. So we've got page 729. Going to hold your guidelines there. Plus we can descriptors and see what we have to say. Additional 30, 45 minutes. Yep. I like D too. Sounds good to me. We've got our B and C is both. Any sessions exceeding 80 minutes, you would be able to bill your prolonged services for those, which are up in the front. And we're going to have a lot more prolonged services codes for 2023. They are updating those. Which of the following statements is true? So big and wordy and a pain to get in and read the whole entire thing. So what I'm going to do is I'm going to look at A and B, and I would look for my commas and see if everything before it is the same or is it after? And it looks like it's just after. So we get down to our first commas. You can code both, or it says if the problem or whatever abnormality is significant. We'll go down to my comma, and if the problem abnormality is significant, those two are the same. Then again, what's the difference then? Requires additional work or requires additional work is still the same key components, problem, E&M. Then you can only code well visit, or you may code both. That's different right there. That one and that is different there. And then this one, after the comma, problem significant, you can only code sick. Okay, we're going to only code sick, or you may code both, or we are going to code both. What would be the answer? And I like to just mark the differences in the questions, and that helps me get through these statements. So if we have a pre-existing problem that's being addressed during preventative medicine, and we end up doing a full evaluation on it, and we do a wellness, then we can bill both, right? Yeah, B. We can bill both. When you get this question, just look for the comma and look for what is different in the big wordy parts. That's what I do when I'm doing the exam questions, because they get really crazy and they'll have the same sentences written over and over again. And try not to read as many words as you can. Stop at the first comma, review and see what's similar in all the other answers or what's different. And that'll help you get through those questions a lot quicker. All right. Why are you all not? Okay. Which modifier is appended to split or share claims for Medicare? Now, we know we have some modifiers in the front cover of this book, but we're obviously not going to have this FS and FT. They're not here. Just in case where they're at, they are located, all HIPICs are located in your HIP book. If you are fortunate enough to get the AAPC version of it, all the modifiers are listed in the front cover and the back cover for easy access. If you have Optum's or somebody else's, E and F. So if you have another person's version, so FS is split, and then FT is unrelated E&M service, then you're going to have to go into the middle of the book, like all the E&M codes are here listed, but usually it's after all those codes. So they're going to be in the back of the book and listed here underneath an appendix somewhere where they're all listed. But there are pages and pages of them. But the AAPC version does have them on the front and back cover in small, easy to find areas, which is super helpful. So if we're looking to find a modifier that will split or shared claim, I believe that was the FT, wasn't it? It said something about an E&M visit. Whoops. It said something about an E&M visit. So I'm figuring that's what they're working on. No, they're talking about the other one, appended claim. Did I find the wrong code? I picked F something else. I picked the wrong one, didn't I? FS is split. Oh yeah, I was thinking of a split cast. Splinting, you know, we were already talking about casting supplies. Yeah, my brain was still doing a cast, but that was the split claim. Sorry. Lord, gotta pay attention. I'm scatterbrained today. All right, we've got our 490. What's going on with that code? Where are we at? if we're looking at the 490s. And these things are very painful to find. Anybody know what page number you got? Because if you're looking up here at the top, we've got to 489. And then all of a sudden they all disappear. Then you got to go see if you can find it. So all of these are all over the place. I'm still letting people in. Okay. So we're looking for the codes for the 490. Let's see what's going on with those. 490. So our 498 and our 497, we're under advanced care planning. We know we're around here somewhere. Let's check it out and see what's going on. If we were doing an advanced directive, we know we're going to be right here in these coded areas. We're talking 50 minutes. This one's 30. This one's the additional 30. So what would we code for 50? I probably have the example here. 50 minutes equals our 97 plus our 98. Oops, I walked away again. I've got an example there in my book where I've got the 50 minutes already written in. You don't have to second guess when you see the question during the exam. All right, critical care again, 291, page 33. I'm just looking for time. I know that this one is a coding irregularity. And get rid of that already. 125 minutes. While doing CPR, we have to take off the time generally for CPR if we're going to bill it, and it is being built for all of that. 125 minutes times 2. We're going to keep our times 2s. Then we just need to know if we can bill for a 4,000 code, which is our gastric intubation. The only things that you can bill with critical care are going to be on that page 59, somewhere in there. Yep. 59 has this column, and I guarantee you there's no 43.7 codes on this list, so we can't bill that one. We could bill if our patient was a child and they were down in the ER or ambulance room, but generally if they're an adult, we don't really bill from this list right here. But if it was going to be able to be billed, it would be on this list, and there's no 4,000 on that one. So that tells you right away that your answer's B, and you can move on to your next question. All right. We got our standby codes, right? Our 460. 460. Standby babies, newborn services. Yep. All right. This is a health record from a newborn delivery in a birthing setting room. What would we bill for this one? We've got baby was born at this time, and the patient was discharged at this time. So they were born at 11 a.m. and discharged at 6 p.m. Sounds like me. I was admitted, I don't know, 8 a.m. and was ready to go home by noon. So same day delivery and discharge. We have one code for that listed here. Anybody know what the answer is? One code told you that it's not going to be those two. Yep, it's in the descriptor of that code, and it tells you that they did the admit and the discharge all in the same day. Yep. I had laundry to do. I went home. I hadn't done laundry yet. All right. So right here we've got ER visits between 84 and 85, so that I'm thinking about the differences between those codes, so I can make a decision. ER, I'm just thinking the differences between the E and M's. So let's check out our question. This one is going to be one of those cases. Okay. So first thing, don't worry about anything else other than picking the difference between the 85 and the 84. That'll help you streamline this a whole lot quicker. What's going to make a difference between it being an 85 and an 84 is only MDM or time, not time, because these are ERs, but MDM, history, and our exam. So if we have a patient in for sickle cell crisis, diabetes, chronic atrial fibrillation, we're put on pain meds. What did we do today? Patient is being transferred to a larger facility, and they want the patient to have some Doppler studies done. Today, what did they do? Before they let the patient leave, they did do some x-rays of his femur and hip. Unremarkable. New onset of diabetes. If the patient is too sick for them to complete and keep, and they're going to send them out, they are on Medicare. We are not keeping our 85s. With this one, we would get rid of the 85s. We're going to keep our 84s. Then we just need to decide, can we bill the 7,000 codes? Which, remember down here, they did the complete x-rays of the femur and hip. That's the 7,000s. So I would just keep D and move on with my day without looking up any of the diagnosis codes. Just having those, and that's the only answer that has the radiology in it. That's how I would do this question. It's just because of what did I do today? And I looked for what they were ordering, but they were going to send the patient to another facility. So then it didn't matter that we made that decision to do that order either. So we did not get to order anything, and we're not going to do any follow-up on the patient. That's why they didn't qualify for the 8.5. Here's your rationale on this one. I've got another case coming up. It's going to be another critical care patient. Is it still blurry? Okay. So you see our E&M codes are all just critical care. They only have the option of just the 191 E&M code. So really no difference there. It looks like they have standby time, just knowing some of this, and CPR, right, is helpful because that's going to help you be able to know what you can eliminate or keep. I'm going to have to scrunchie this down because the case is pretty big. But we've got a 37-year-old. And what happened? We did, well, they did it in route probably. Who am I billing for? Let's go down here to the bottom and see who am I billing for. E&M visits, services provided to the patient. Patient arrived at 11. Code was called at 11:45. No response. Full arrest. Full arrest is a key term for knowing how to bill services rendered in the E&M section. There is a bit of a guideline there for that when you see patients in full arrest and they show up. They arrive 20 minutes later after the patient was found in the bathroom. They were down quite a while before they managed in. That first hour is key. Anybody know what we could bill? Would we be billing any of these services when they arrived into the critical care department after being down and being given CPR and epi and all that stuff for 20 minutes in the field? Then they come to the ER. We work on them another 35 minutes before we pronounce them. How would you code this? And I'm sorry, it's so blurry. It really likes me to zoom in on this, but then you can't see the whole question if I do that all on one screen. So we are not going to be billing. Where's my drawing tool? Our 60 is outie, and we're not going to be doing any symptoms. So those are outie. We're not going to do any symptoms. We're only going to have the cardiac full arrest diagnosis no matter what. And then we can also charge for the CPR, and that's it. We wouldn't bill for anything else. Just on those diagnosis ones, easy to get rid of the ones with the symptoms. Just keep your cardiac arrest, keep your CPR and your critical care, and that's it. Whoops. There's your answer. Oh, here we go. The additional code for the epinephrine would not be going. We'll just capture it for, they're saying charge master, that just gets captured for purposes, how much we spent, and that we need to reorder some more, but it doesn't go into the claim for that patient. Right here, we've got all the same diagnoses except for the 10 and the 20 on the third one. Keep that in mind. Then we've got just the differences between E&M visits or a 908. 908 was psych therapy again. So on this case, let's see, who are we billing for? Are we billing for psych or are we billing for like a primary care physician? And so I go down to the very bottom of the case and it says we are going to be billing for psych, right? So we know that's could be a possibility. Let's see. Right here in the chart, 50% of the counseling time was marked no. We have a problem focused and a straightforward. What would we bill on that? There you go. The chart had checked no when it said 50% of the time spent with the patient was counseling. They marked no in the chart. So are you sure you still do? Now I know the bottom answer or the question they're asking you does say psychiatrist here, but if a psychiatrist did not spend 50% or more of their time talking or counseling with the patient, they did more of the time discussing, I don't know what, review of their meds, maybe the medication wasn't working that day or something unrelated to counseling. And it's probably just because of the meds aren't working and we need to switch meds, but they didn't do any counseling. We cannot code anything from the 908s. Think about it again. One more thing. Look down here. We've got a problem-focused history, a problem-focused exam, and the MDM was straightforward. If our MDM is straightforward, can we bill a 14 moderate? So you know your answer is B, yes. There you go. Yep. I knew this one would come in handy. Yep. And it's going to be B because of that 50% of time. Let's see. Yep. All right. We got a difference between new patient or established. I'm going to check that out real quick. We do have new patient. So we're going to just keep A and B. You don't have the CPT book. That's okay. That's awesome. No worries. I hope it was fun to learn it anyway, that kind of way. It's neat. So we're going to stay at A and B. So what is the patient being seen for? They're being seen for today for diabetes, arthritis, and hypertension. I had this one during a live last week and everybody got it wrong. So if we're 03 or 04, all conditions are stable. We have labs ordered was just the hemoglobin A1C and follow up in 3 months. 1, 2, 3 diagnoses. Yep, we have no medicine reconciliation going on today. No labs other than just one done. So we would definitely be here in the test area or documentation. Any combination of 2 is going to be in this area. We reviewed results and we ordered a unique test. If it's just 2 of them, if we ordered 3 things, we would be in moderate, but this one's going to be limited. Yep. Yep. Very limited. All right. What kind of code is our 231? 99231? Are we subsequent hospital? 231? We are subsequent hospital. Subsequent hospital. This one, 18 is that discharge or admit? 18 is admit to observation. Observation, admit. 221 is our admit hospital. And 32 is subsequent hospital. We have 2 that are subsequent hospitals. So probably going to be a difference between those 2. Let's check out our question. So we've got a physician called to the floor. We're working on a chest pain. He aspirated. What would we bill for this patient? How long did we work on the patient? Chest x-ray, labs or order, ventilation management. Is this going to be an observation, an admit hospital, subsequent hospital visit? It is going to be a subsequent hospital visit, but what is our differences between the 3-1 and the 3-2? Problem focused, or are we expanded problem focused? So when looking at the patient, what did we deal with? The patient was admitted for COPD. We listened to the patient's chest, lungs, and he gave instructions off of that chest. If we were going to bill expanded problem, the doctor would have looked at another body area like neuropathy or respiratory. No, we did look at respiratory, circulatory, something else. This seems to be more of a problem focus, just all related to the COPD. So this one would definitely be A, just because of the doctor's exam that day. Remember, if you want to move up in the coding level, they have to look at more body parts than just what they're dealing with. This one I was trying to do so that you can look and try to do the process of elimination with me. So if we were looking at this one, just from a numerical point of view, this is what I see. I see everything has CPR in it. I already know what that code means. I see that 3 of them are in critical care and 1 is in ER. So I would get rid of the ER, right? Because it's not the same. So we got all yellow, all green. All the 3s are all the same right here, except for we got 1 more oddball right here. This one doesn't have the 3000 code when the other ones all do. So I would get rid of C too because of that. Now over here, the last code, the similarities are just that these 2 codes are the same, but this one doesn't. It has an oddball in it. So then I would get rid of that one. So that leaves the only answer that is possible for this one, and you would just pick that answer and move on without reading the question. Does that make sense? Because for every oddball, you throw it away. And those 3 oddballs get you to the answer without having to even look at the questions. Yeah, it is scary. But even if you could get it down to just a 50-50, then that's great. But truly, that is going to be your answer. So let's check out your question. We have a 5-year-old brought into the ER. So what did they do? EMS started that. They did an endotrach intubation, which remember on page 59, we'll have the list of all the items that you can bill for. So if we're looking for the 36556, just look through these codes. 36555 is there. I'm sure it's here somewhere, around and about. That one's going to be there. Our 31550 is there. That's for the endotracheal intubation. So those things we can bill if they're pediatric patients. If the patients are over 6 years old, you can't bill for these if it's in critical care. In the ER, in critical care, we don't bill it. But if it's peds and they are under 6, we can, and anything from this list. Oh no, yeah, it takes practice. It does. But we've got our CPR, we've got our urgent, our critical care, which is right there. We do have to take off 5 minutes for each of these, the endotrach and whatever, so it ends up being 50 minutes of critical care, but that's okay. We still only have the one code. We did the CVC and we did the endotrach. And that is the answer. If it had been an adult, we would not have been able to bill any of that. We would have only been able to bill the CPR and this code right there. We don't bill any of these if they're an adult. All right, we've got ER, critical care. What's our 475 and 476? What are those codes? Right here we've got pediatric, inpatient. Our differences are ages. The 75 is 2 to 5 years. Sorry, I went away, didn't I, from the phone? So our 75 is 2 to 5 years, and our 76 is a subsequent visit for a pediatric patient who's also 2 to 5 years. So one thing I'm going to need to know is how old is my patient? That might help me with this question. We have a 3-year-old. Okay. Where are they at? They have been admitted to PICU. So if they're admitted to PICU, what are we going to bill? We got a comp history, comp exam. Yep. This one's subsequent, this one's admit, this is critical care, and that's ER. C is our only one we can bill for. Yep. That is it. All we needed to know is that they ended up taking that kid from the ER and admitted them to PICU. Before they did anything, it's the first line in the sentence. It says they admitted the patient to critical care unit, and that's when the doctor started doing the ventilation management, bronchotherapy, and pharmacological support, which we do not bill if a patient has already been admitted. If they got all that done down in the ER, we could bill for all that extra stuff. But just so you know, once they're already admitted, peds patients, you don't do that. Adults, you do, you could bill for all that, but for peds, we don't. Got to be less than 6 years old. Let's see this real quick. Let me get rid of that. On page 55, what time is it? Our 238. What kind of code is that one? 238. 237 discharge. We've got hospital discharge. 231 is our subsequent hospital. 221 is admit hospital, and 283 is ER. So keep that in mind. So I'm just going to look and see. They were admitted to the ER hospital. So that gets me to most definitely get rid of the ER one right away, right? Following an ER visit, an MDM visit, motor vehicle accident. Down here at the very bottom, what are we coding for? We're coding for a patient's discharge. And that would tell me right away, we know our answer is going to be A, right? We're just doing the discharge today. Super easy. Just look for the word admitted, and then I looked for the word discharge. That let me know, yep, we're going to just bill for the discharge. Super easy. This one is a hospital consult. This is an office consult. This is an ER. And this one is admit hospital. Super handy to know those differences. So we have a Medicare patient, you know, that matters a lot of times. We have detailed, and MDM is moderate. That's helpful. What do you guys think is the answer on this one? They're in the ER. Yeah, unfortunately, Medicare and paying for consults is probably not their forte, right? They don't like that. They don't want to pay for much. They don't want to pay for observations either. We learned earlier today. So this one would just be our lovely ER visit. Yep. So anytime they say the word Medicare, don't think that it's an unusual answer. Whatever they're alluding to that they want you to bill for, don't go for it. Just bill what would be unusual. I always tell you, no one's in the ER unless they're a Medicare patient. That one's in the ER. Gotta love it. Here's your rationale on that one. This one's going to be all in the ER too. We've got a level 2, level 3, level 4, and level 5 ER visit. So let's pick out our rationale. Let's see. Do we have any MDM? No MDM that I see. Of course not. No MDM. So let's pick out. Are we doing otitis media? Amoxicillin 7-day prescription was given. This is usually OTCs, right? This is usually 7 days. This is usually 30 days. And this is usually, we're going to keep you. So we do have a limited exam, which is our keyword right there. If you do look at our page 17, you know our limited is with our 3s. So B would be a good bet with that one. Yep. I was trying to make it bigger, but it didn't work because I got it on draw. All right. Problem focused, expanded problem, detailed or comprehensive. Thinking about those differences. How many body parts are reviewed? Just keep thinking about how many body parts. So we have an exam of nose, throat, neck, chest, and abdomen. What would these have in common? The HENT, and then the neck, and then the chest. If we look at our Homely Body Systems on page 11 that I have done, one body area equals our problem focused, 2 to 5 equals expanded problem focused. That might be a good place to go look at for the answer. So I consider the neck included if I was the clinician in with anybody having any kind of runny nose, sore throat, whatever. And then it's just expanding to the chest too. So anyway, that is an expanded problem focused right there. Yep. 2 to 5. Yep. It's going to be something for me to get used to, but I kind of like it. All right, we've got ER. Good gracious. ER. And then I have consult and 252. Is that consult too? I think it is. For the hospital consult. 52. Yep, inpatient consult for hospitals. Yeah. So patients in the ER, we're doing expanded problem-focused history. Which one of these is expanded problem-focused history. There's our two. There's our eight. Eight. Expanded problem-focused is an 83. What's an 82? 82 is also expanded problem-focused. We got two of them. The exam was moderate. Our exam, moderate. This exam is expanded problem focused. This exam is expanded problem focused, but a moderate exam, we got comprehensive, we got detailed. Yeah, moderate MDM. Any of them have the MDM moderate, the 83. But this one has low. So just the difference between those two. ER has to match up all three. History and exam are the same. So as long as we've got all three, we do have expanded problem focused history and expanded problem focused exam. Yep, and moderate all in one. Yeah, I like our 83. Yep. It's confusing when they have the same descriptors in these, but I think next year, because they're making this one into a nurse visit, it's going to put these all in a line better, where we don't have two of them with the same descriptors anymore. So I think it's going to be a little bit better. Yep. All right. We got critical care. And we got admit baby. It's our 466. And then we got ER. We got 466. Our critical care during transport code. During transport. So where is the baby? Who are we billing for? They did everything in the ER. So if we have a 28-day patient who's in the ER getting critical care, we get to use everything that's on the page 59 because the patient is not admitted yet. We do get to bill for all this stuff. It's just a difference between, do we bill ER or do we get to bill critical care? Because we do get to bill all this because they are a PEDS patient. What you think? Are we billing ER or critical care? Yep, we're going to bill critical care. Good job. Just checking chat. Good job. All right, we got established patient, right? Is that consult 244? Pretty sure. It's a high level consultation, but yes, that is consultation. New patient and a consultation. Yep. So let's check out. What can we do with this patient? We've got a second opinion to an orthopedist surgeon. Evaluation. Doc evaluates patient and does a comprehensive history, comprehensive exam, and MDM is moderate. After the consultation, the doctor does write a report back to the PCP. What do we get to bill? Yes, I can go back to the one with critical care baby. This one's going to be our new patient. Most anything during the CPC exam that says anything about a consultation, 99% of the time, it's always going to be just a new patient and you don't actually really get to bill your consultation codes. This one is because the patient decided to obtain a second opinion and it wasn't the PCP's decision and it was just the patient's decision. So that's why it's a new patient. This one is critical care because the patient came into the emergency room under full arrest for SIDS and they performed critical care trying to resuscitate the baby, even though they were under full arrest. It's another one of those arrest ones. We definitely get to bill for critical care. It will include paying for, epinephrine, the shocking of the baby, the heart. There's a lot of other things that aren't on that list on page 59 that you do to a patient during a full arrest that you don't bill for, and it would not be covered under just an emergency room visit. Full arrest is definitely going to be in your critical care. You'll have a team of people working on the patient at the same time. All right. We got another critical care. So we just need time with this one. That way we'll know whether we can bill. It looks like we've got it either ×2 right there, or if it's just ×1. So let's check out. How much time did we do? We did 35 minutes of critical care. So we know we're not going to be billing D. And we know we're not going to be billing C because it doesn't even have an E&M in it. And we're in the E&M section. So we're most definitely going to be billing one of these. Our patient's age, that makes it clear that we can't bill anything on our page 59 with them because they're an adult. We only bill for critical care because all that's included. So we know it's not going to be B. No matter what, the answer is going to be A. And this one was 1 hour and 35 minutes, not just 35 minutes. That's why it's the 2 codes. You've got the 1 hour and then the extra time right there. The chest x-ray, the ventilation management, all that stuff you do not bill just simply because it's an adult. If it was a pediatric patient, you could. All right. We've got an established level 4, an admit hospital, a new patient, or admit hospital. Let's see where our patient is. What did they decide to do? Where is the patient? Admitted Adam to the hospital. So we know we're not going to bill an established. We're not going to bill a new patient. It's going to be one of these hospitals based off the MD 222. Are they afterwards? I'm just going to match up the MDM is on GSP. We've got our comprehensive history, comprehensive exam, and MDM is moderate. So that's our highest level anyway. Yeah. We're going to be in our 223s, all right? 222s, 222s. Because we can't bill for the office visit on the same visit. In real life, you absolutely can't bill an office visit and an admit on the same day. It's one of those, if you do see a patient in your primary care physician's office and you send them to the emergency room, it's a no charge for that day. You cannot bill for both, especially since that doctor left his practice and he went to the hospital and he did a full evaluation and admitted the patient there. So you know you're just going to be billing B anyway. Yeah. All right. This one's got a ton of codes. We've got office visit, admit hospital, subsequent hospital, or admit hospital. These two are admits. That's more important. I wouldn't bill a regular office visit with an admit or subsequent hospital visit. So we just discussed that. You can't do that. So that's going to be an outlier. We've got 2 admits and 1 subsequent. It's probably going to be the 2 admits, right? Then we are billing 4 codes versus 5. Let's check our question, see how much we're answering, see what we're doing. This is right here. How would you report services from day 1 to day 5? So this is 1, 2, 3, 4, 5. So you know your answer is D, no matter what anyway, if you're just counting how many days. But you don't want to stop and start coding the admission was a comp and a comp with a high, and then go find that code, and then go try to match up your next 2 days were expanded problem focused and moderate complexity. That does equal up to your 3 2s for the 2 more days. And then your 3 1 is for day 4 where you were a problem-focused and a straightforward decision. That's why it's a lower, number 1. And then we've got our discharge, which is our 3-9 on day 5. Day 5 is a discharge. But I find it's a lot easier. Just go look at the last sentence in the question, see how many days you're going to bill, and count, and see if you can't get it down to a much lower number for you. All right, we've got a consult, hospital consult, and new patient. So we've got the doctor's office. Patient was sent to a doctor's office as a request from the PCP because the insurance company requires a second opinion. So we're definitely going to need that 32 modifier because 32 is a mandated service, I believe. You can look on there. Yep, mandated services. So we know our answer is going to at least have a 32 on it. Are we doing new patient or are we doing office consult or hospital consult? What do you guys think? It does say office, so I bet we'd get rid of that hospital one. Good job, Heather. Yep, we're going to be new patient. Most people just do not get that consult. Even if the insurance company requires a second opinion, it still wasn't the PCP's idea. They didn't want the patient to go get a second opinion. They were managing their health just fine. But the insurance company demanded a consult. That doctor does not get to bill a consult. That doctor gets to bill a new patient visit. The only way you bill a consult is if it is solely the decision of one doctor to have a patient go see another patient, another doctor, for one condition that they won't take care of. This doctor will still be in control of their health and will want to report back saying, how do I treat your patient? So if I send my patient to a lung doctor to get their COPD under control, I've tried the albuterol, I've tried tons of preventative medicines. They're getting worse and worse. Let me see what the pulmonologist has to say. That pulmonologist will see that patient, send a report and says, yeah, add Advair to they need an antiviral once a month. So add that to their regimen. They're going to feel a whole lot better. Okay. And then that doctor will start prescribing that prescription that the pulmonologist said. Now, if a primary care physician just turns over all the care to another physician, it's also a new patient. If an insurance company demands they see for a second opinion, it's also a new patient. If the patient's Aunt Sally Sue said, go see my orthopedist, they're perfect. They're going to get your foot pain under control. Your primary care physician doesn't know what they're saying. It's still a new patient. All right. Looking at the process of elimination with this one, we got to try to use it everywhere we can a little bit. We've got this one with the 3-8 looks abnormal. Plus, if we look at our 99465, we do have some do nots, and it will tell you do not use with the 6-5 and the 6-8 together, right? 6-4 you can't use. 6-4, 6-5, those kind of things. Super clear on that kind of stuff. So important. If we're going to bill these, remember you got to have a peds patient. Do we have a peds patient? Let's see. We do have a peds patient. We're going to get rid of that one. It's our oddball. It's not like the others. We can't bill the 6-4 with the 6-5 according to our do not. So we'll get rid of that. We know we have a peds patient. And if we did these, then we get to bill them. Did we bill that? Did we do something? Yep. We did get to bill a resuscitation and an endotrach intubation. So we have those two things and we do get to bill them because we have a peds patient. If it had been an adult, it would have been A, but since it's a peds, we do get to bill D. All right. Another kind of weird, interesting new one. We've got our 234. What kind of code is that one? Our 234. Observation. It's admit and discharge all in one. That's more important than anything else. Make sure you know that the third line in that descriptor is the most important line. It does admit and discharge all in one code. This one is just admit hospital. And what is our 3.8? Is that discharge or something? 3.8 is discharge. So let's check out our example, see what we get to bill. Ooh, we got another Medicare patient submitted to the hospital and discharged 4 hours later. What do we get to bill for this? Now that you've seen me do a few of these, what would we bill? Remember, their Medicare does not pay for observations. Medicare does not pay for observations. We cannot bill the usual when you see Medicare. They were admitted to the hospital and discharged 4 hours later on the same day. How do you bill this encounter? We don't just bill the discharge either. We can't just bill the discharge. It's so funny. Yep, we're going to bill B. We are going to bill B, just the admit to the hospital. Insane, isn't it? This is according to a CMS note that they wrote to hospitals and asked them to start billing for that. So the publication is listed there. It's crazy, insane, very unique. Hey, Rebecca. All right, we've got our admit hospital. We've got our critical care. We either have admit hospital and critical care, or we have critical care and admit hospital. Let's see what's going on. Have we done this one? Let's make sure. Yep, we got another Medicare patient. That's the one that had the fall. And he also had the chest pain. I've already done that one, but just as a reminder, we are going to bill for both. We're going to do our regular little into the hospital, remember, and we're going to be doing our critical care, which is the most important thing that we did that day. That's why it's the first thing, which is our chest pain, even though it was later in the day. We'll do our critical care, and then we'll do our hospital due to a fall. All right. We've got an ER visit. We've got our hospitalization consult. We've got our admit observation, and we've got observation with our admit and discharge all in one code. What have we got going on today? Emergency room visit. They had a surgery a week ago. We did a detailed exam, moderate detailed history, gave them the good stuff, told them to call for a consult, whether we're going to admit the patient or not. So we called in a neurosurgeon to have them come look at the patient, see if we can let them go or admit them. What would we be billing for the emergency department physician? That's the most important sentence always, usually in these questions. Be sure and check your last sentence, because am I billing for the neuro? Am I billing for the ER? Who am I billing for? And that will keep you straight. So ER 8.4, does that match up with our detailed moderate? Detailed moderate, it does match up, right? Yeah, but what did y'all say? I don't know if those answers are from that one or that one. Are y'all gonna bill the hospital consult and admit to observation, admit and discharge in the same day, or ER visit? If you're a patient and you've been seen in the ER, you've been treated in the ER, but you can't leave and you're told to wait, What does that tell you you have to do? It means you're going to be in observation. Now we just have to decide, did we admit them to observation or did we admit and discharge them? And since we cannot let them go and we haven't discharged them yet, they are just an admit into observation. Super tricky one right there. Super difficult. And even though you can see that they're trying to make you match up your moderate, detailed, and detailed right there, it's why they're trying to push you towards A. Just be careful. If the patient can't leave and they've already been treated in the ER, then they're observation. Yep. Another one, we've got our babies, which can be super tricky. In our page 59, we got those. We're over here, our 468. We're here, 71s. These are divided by patients' ages, right? So these are for older kids, 1 to 2 years old, 2 to 5 years old. We see our patients 10 days old, so we can get rid of these just because of the patient's age. Plus, we have 2 that are the same. Looks like doc ordered blood glasses and an endotracheal intubation, and baby was put on ventilator. What answer did you think it was? I didn't like that question. Can you explain the X from the last question? X on the last question. Yeah. So this one's super tricky. So if you come, so observation is just a vague, it's a vague, there's not like a building for observation. If you come into the ER, you have a waiting room, and then you have the back where you could go see the doctors in all these doctor rooms, right? There's no distinction between critical care, ER, and observation spaces. It's all the same ER. They don't have a designated area for all of this. It's just all ER. You're either out here forever looking for snacks in the vending machine or puking your guts up, or you're back here seeing a doctor laying in a gurney. And sometimes you could be in the hallway in a gurney, just behind the registrations desk. Who knows? But your status is what's the difference. You're either in critical care, in the ER, or in observation. So that's one key point of this question. So we're not worried about the physical location of the patient. We're worried about the status of this patient. So the patient was seen, they were treated in the ER, and then they called in a consult to see if we need to admit the patient. Until then, the patient's got to stay and we'll observe them, because it's super important not to let them go, because they just had lumbar fusion a week ago. And it's a gray area. You're having to, as a coder, assume a more clinical situation than in general you should be responsible for. And they understand that as our coding representative areas, is that you really do have to put a little bit of clinical knowledge into this question to figure it out. And it's really unfair that you have to think about that kind of stuff. But it is part of some of the stuff that we are required to do. But this periodic assessments to monitor also is really good wording you can put next to any one of those observation codes over here. In my notes under observation, I've got a ton of things like wheezing, increased heart rate, keywords, that mean that we're gonna be in observation, are super important. One of those that we could actually put over there is periodic assessments. That would be another good one to put in there. That would be just gravy. along with all that stuff. But any kind of monitoring, I've got continuing examining the patient. We could put monitoring right there, but that one sentence will clue you into to let you know that they're admit observation and we're not letting them leave. So that's probably more helpful to point out that word. This one, 10-day-old. Are we billing for the stuff that we did or not? Are we A or B? Thank you, Twinkle. They're admitted. Remember, I told you when they're peds and they've already been admitted, before you start doing stuff, you can't bill. So it's really confusing, and I know. If you do a trach and intubation or ventilation down in critical care or in the ER or in observation, then you can bill for it all day long. But if they've already been admitted, you do not bill anything for peds. You just bill your admit code. And it's the complete opposite for our adults. The one before it, she was talking about just the X's. Those are just like, instead of doing 99221, 99221, 99223, 99224, they mean all of them in the 9922 areas. This is 99291 or 92. And this one's 99291, 9293. Super simple. It just means that whole section of codes is all that means. All right. Are we doing a 99305, a 235, a 222, or a 310? We've got admit hospital. What's our 235? General observation? 235? No. 235. This is admit and discharge too. So observation, admit, and discharge. It's our 305. 305. Admit nursing facility. And 10 is subsequent nursing facility. All right, where is our patient? Good Lord. Admits the patient. Can we bill office visits with admit visits? No. We're not admitting the patient to observation. We didn't discharge the patient. We're not at the nursing facility. We ended up admitting them to the hospital, so we can only pick the only key one, which is admit hospital. Hey, Suzette, this one, if we're gonna do, we just need to know if our patient is new or established. Our patient first time, so we know we're gonna keep our new patients. Now, to be able to bill this, I just need to know our time. Did we go over in time? Our 99205 has a time of, the new patient has more time. New patient is 60 to 74. So we're just looking for time. We did 65 minutes. I know I didn't go over 74, so I do not bill that. I'm keeping my C. C is my answer. Move on with my question. Yep. Okay, we got critical care or subsequent hospitalization or just a procedure. So let's see what we're doing. What happened to this patient today? Patient is already in the critical care unit, so they've already been there. We did an expanded problem-focused exam, and we did a complex medical decision making. Critical care was 30 minutes. It's an adult. We get to bill for the 315 that's on our page 159. not 159, it's page 59. We get to bill for that. Our 315 is the endotracheal intubation because they've already been admitted to the hospital. If they've already been admitted to the hospital, they're an adult, we do get to bill for that. They only had 30 minutes of critical care time, but if we're going to bill for this, we have to take the time it took for the doctor to do that intubation because we're going to bill for it. And you see how they put 5 minutes there? We have to take that off of the 30 minutes of critical care time, which means our critical care time was only 25 minutes. And I don't know if y'all can see what all I've written up there. So in the 291 area, in critical care, it says right there, anything less than 30 minutes, we have to bill their appropriate E&M visit. So since they're already admitted to the hospital, it's just going to be a subsequent hospital visit. And we get to bill for the trach. And that's it. We do not bill for critical care time for this one because it's an adult. And because they're already admitted and because we got to take off for the trach time. Sorry, I'm moving fast with these. I'll explain and do these again during the lives this week. All right, we've got hospital consult. We've got office consult. We've got admit hospital and subsequent hospital visit. It's really handy if you know those like that during your exam. So we got a patient that was admitted last night. So that tells me we're subsequent hospital, right? Unless they're under observation. We're definitely not going to be admit hospital. And if they're admitted to the hospital, we're definitely not doing an office consult. Let's see. Who am I billing for? I am billing for the cardiologist who was requested by the primary care physician. Who admitted the patient to the ER though? I guess the primary care physician did. So that's cool. So yeah, does it match up? Comprehensive history, detailed exam, and MDM was moderate. Is our 253 detailed? 253. I'm doing this. Is it detailed? It is detailed. Then, hi, yay, we do get to bill that. Don't see a problem with that at all. Perfect. Okay. Yep. All right. We got 219 and a 225. Or, so we got admit hospital, subsequent hospital. 225. We've got our observation. And we've got admit hospital with admit observation with subsequent. Interesting. All right, let me check the bottom answer and see what are we billing for. The patient codes, we're going to bill E&M codes to report 3 days in the observation unit. So most definitely, you're going to bill your admit, not times 3. We didn't admit them 3 days in a row. So that's definitely going out. We are going to bill an admit code with our 2 subsequent observation days. So admit 219. Yeah. That one is detailed, no comp, and moderate. Do we have comp, moderate? We do. We have comp, and moderate that matches the 219. Perfect. And then our 225, our subsequent visits are expanded with moderate. Did they say anything about those? Maybe. Yep, expanded and moderate complexity. Perfect. I like A. We would pick it and move on with our day. So that's admit to the hospital. That's admit and discharge all in the same day. And this is for 3 days stay. So A is the only one it could be. All right. We've got nurse visit and over-the-counter meds or a 7-day prescription. And we've got a patient who is seeing a physician for a scheduled procedure. That is clue words to let you know that we may not even be billing an E&M visit. Because if you don't do a history, you don't do an exam, and you don't do an MDM, all those three things, you can't bill one of these. So what we did a brief exam on the shoulder. So at any point, it's just a problem-focused exam, but there was no history, and it was just the procedure. And there was no medical decision-making or follow-up noted. So most definitely it's D. We're just going to bill for that aspiration of the shoulder and move on with our day. Initial observation. All right, we've got a difference between the 6.4s and the 6.5s. I do have the changes in 2023 coming up in some questions. I have some new 2023 questions that I got from a webinar and from AAPC. They're going to be super cool. What page number am I on? I'm on 78. So the last 10 here ought to be around these changes. Let's do this last birthing center one, probably, before we get into our 2023 new ones that I've not shared. All right. And our 465 are birthing centers, right? Is that our birthing center? 460. Yep. So we need to know, what's the resuscitation done? Or is it just the doctor being present during the delivery? So we're looking, I see blue, baby is blue. Did we do? Yep, positive pressure ventilation. So we know we did CPR, whatever, to get the baby breathing again. So we're definitely going to get rid of A and D, because the 4 codes have no resuscitation. So we'll keep these. Then we just need to know which one of these we would omit. Since it's a newborn, we know we can't bill the 7.1 because that is a code for 2-year-old babies. And this is the only one that's the 0 to 28 days. So definitely we're billing just that one. And I don't know why they didn't bill for their CPR. They could have, but it's okay. All right, we've got observation. We've got admit into the hospital, observation, and then observation and discharge. So let's see. We got our patient who was admitted to the hospital. It doesn't mean it's a 2-1. We've got a detailed history, detailed exam, and a moderate MDM. Later that afternoon, they did some work, and then they discharged the patient in the afternoon and told them to follow up the next 2 days. So most definitely, since we admit and discharged all in the same day, we're only going to be billing A. Super important. All right, here is your 2023 new updates. So everything from this point on is going to be 2023 January codes and on learning, okay? So which of the guidelines should we use to level any E&M services during 2023? You remember how we had the 95 stuff to look at, the 97 stuff to look at, and the 21 stuff to look at? That is all going away, thank my goodness. We are only going to have these to look forward to. Now, if you're in a job and you start one in 2023, think about your dates of services. If you're reconciling claims from 2022, you're still going to have all 3 of these guidelines to mesh together to produce your level of visits. So think about that. But anything after that 2022 dates of services, we're no longer having to mash these up together. We're just going to have straight these. Okay. Custodial care services, home care oversight services, or hospital inpatient services. In 2023, domicile, rest, boarding, custodial care services have all been deleted. And you will now use what codes from which category to code all of those. Domiciliary, rest home, boarding, custodial care services have been consolidated. I see 2 of them have home in it, looking for similarities. So that sort of makes me want to do my process of elimination. Do you think they would call it a home service or home care oversight service? They're actually keeping it super short and sweet and just calling it home services. Whether you are in a rest home, whether you are in custodial care, or a home health agency is coming to your house to look at you, it's just all going to be under home services. Wherever you live, if you live in a domiciliary, that's your home. So they're just calling it all that. All the assisted living, you name it, all of it's going to be just home. So when they trim this section down, they trimmed this section down. They deleted 10 pages of codes and stuff. So they really did. When do the E&M guidelines go into effect for our new 2023 year that I was talking about right here, where we have all of these codes meshed up together for part and then that. So when do they go into effect? Is it January, October? It's basically your differences. And yep, thank goodness it is January 1st. No October. Nope, no October. We do not have to wait till October. They are going into effect January 1st. They're not playing. They are done with all that meshing up of the 95 and the 97s years. All right, so for 2023, looking at these codes, which one has been deleted effective January 1st, 2023? Bigger for you guys. Which one has been deleted? Anybody know? So 281, it's not deleted. Remember, I told you it changed to a nurse visit. That's our very first ER one. So that's going to be there. Our subsequent hospital, which is our 231, that's going to still be there. So now you know it's between these 2. Good job, Stacy. Yep. It will be C. Yep. It's that level 1 consultation codes. They're all going away. All right, which category of E&M has been deleted effective January 1st, 2023? Is it office and other outpatient services, consultation, nursing facilities, or observation? Which ones have been deleted? Yep. All the observations are just going to be inpatient hospital, because technically they're still inpatient hospital. They're all in the hospital. They're just in the ER. Yep. All right. For 2021, 2023, if we have a 221, 2223, yep, those are all admit hospitals. So which code is used for report for initial hospital inpatient care that supports a moderate MDM decision making? Shouldn't have changed much. There are some time changes on some of the codes, but I don't think the MDM is changing except for the ER one that is changing to a nurse visit. But they may be streamlining these just a little bit. And it is going to be, this one's going to be our low, this one's going to be our moderate, and this one's going to be our high for 2023. What 3 document requirements are required to support using the consultation categories of codes? Must the request come by another provider, request by a patient, recommended, or requested by the patient? We've got requested by the patient twice, but you know that consultations technically can't come from the patient. So I think that's just them trying to trick you. So probably C or A. It's A. We've got to have it requested by another provider with that written report coming back to them, telling them that they've got to use whatever means they said, whether it's writing a prescription or sending them to physical therapy. They'll just give them instructions on how to treat their patient, and that's it. And that's it. That's all I had prepped for tonight. I hope this has been helpful for sure. I know some of them I had to go through pretty fast. Be sure you got down some of these definitions that I did not go over in the beginning. Which system is an exam component? If the provider discusses range of motion, yep, you're talking about muscular skeletal. Thanks, Twinkle. I couldn't have done it without all your help. Good Lord. Grab your one-word differences and add them in. E&M section is first divided in the CPT manual by what? And a lot of people don't even know where that is. In the first part of the book, it's your first page in the book, which is the place of service. Be sure you know where these numbers are. That will definitely be on the exam. You will definitely need to know where a place of service is. Review of systems is an inventory of body systems used that helps out with the patient's medical history. MDM includes the cognitive, remember that? That was funny, the cognitive of the doctor, cognitive functions. I hope it was helpful. It will definitely help you get better scores on the E&M section, which is so important. New patients require a higher degree of documentation plus the 3-year mark. So make sure that's the most complex thing that a doctor documents is the stuff on their new patients. 3 components are called history, exam, and MDM, and they are amount of resources that are performed by a provider to render the services. I'm happy to help. Happy to help. Gives me something to do. All right, problems that run a definite and prescribed course is transient in nature and is not likely to be permanent, is a self-limited or minor problem. That OTCs, we tell you to go home and stop eating, maybe do the brat diet to alleviate your bellyache. That is what they're talking about in fancy terms. A transient in nature. Chronological description of development of patient's present illness. I have anesthesia done and just the CD10 notes, but that's it so far. I'm almost done with my E&M notes. They're coming along really well. I'm just looking for more 2023 E&M questions from PC and waiting to see if January 1st, if all of our exam questions that we pay for, exams A, B, C, D, E, and F, if they change all to the 2023 guidelines, then all their questions will change. So as soon as that hands up, I'll do it. But no, you can use your 2022 books. I have a document on my website that will tell you which codes to delete and which ones to write in for 2022 throughout the whole entire CPT book. And the good thing about it is that you can't read my chicken scratch. I also took a picture of the 2023 book of what the descriptor says, so you can actually see how they typed it out in case you can't read my handwriting. But I have a picture of a 2022 book and how I changed it to be a 2023 book with my own handwriting. But then I gave you pictures of what the 2023 looks like too, even if it's a CPT code or whatever. So it's pretty cool. Yep. All right, some more definitions for those that are just hanging around listening. Limited and chief complaint or brief history is always problem focused. Family history is, of course, hereditary. HPI is the risk. It helps to know what kind of risk. If you have a history of being Evel Knievel and flying motorcycles in the air, then that's context that the doctor needs to know. And it affects the quality of your life. So that's how they do HPI. Treatment is the presenting of problems and are dealing with your symptoms, treatment, and finding your illness, collection of details relating to the chief problems regarding signs, symptoms, and behaviors and genetic conditions. That's always your PFSH. And anticipatory guidelines is trying to give you some behavioral modifications, that kind of stuff. When I started working from home, man, in 2013, I didn't realize having the refrigerator so close by all day long would have such a huge impact on me as it did. So that was a anticipatory guidance I did not get. So be sure and put a timer on yourself so you do not go to that refrigerator all the time. But man, I'm so happy. I met, y'all know Miss Edwards. I talk about her all the time. She's one of my students that is helping me. I'm helping her pass, but look what she's done to my weight since I've met her this year. I was way on up here and now I'm down here in the 157 area. I'm all like, woo, just doing what Miss Edwards does. And she's got that Instagram thingy with the juicing and stuff. So it's cool. The YouTube workshops are available for the YouTube paid subscribers. This replay will be available to you since you purchased it on Zoom until I eventually move it over to YouTube, but it'll take a long time. Like I just posted July's workshop up on YouTube today for the subscribers to review. It's 6 months old. So about that time, I'll move it over to YouTube for the paid subscribers to have something to look at because maybe they weren't around 6 months ago. But this one will be on Zoom for 6 months and you'll have the log on and password so you can look at it exclusively whenever you get time. You'll be able to have full screen views of my book and the questions at the same time when this replay comes out. Yeah. And that's it. I went over all the rest of the questions. So I hope this was helpful. Had a couple of repeat questions, but other than that, I had 87 freaking pages of all E&M. So that was fun. Love E&M. And I'm going to love it even more in 2023 because it is going to be way easier to explain. All right, guys. I'll see y'all later. Good night.